Hello, good afternoon from Vienna. On this 15th June 2023, welcome to our second hearing roundtable within this year, and thank you for joining us. Thank you for those who have been here already on those wonderful hearing roundtables, and for those you're here first time, a very warm welcome. This time we selected another very nice topic about the electrodes and the electric neural interface with an outstanding faculty. But first, some words about the hearing. We founded ourselves in the year 2007 and started our activities in the year 2008. And this is us. The hearing is a comprehensive group of different people dedicated to hearing and hearing research. We are physicists, electric technicians, therapists, rehabilitation people, teachers, surgeons, audiologists. And we're all together to improve the world of implants, cochlear implants, bone bridge implants, any type of hearing, also concerning hearing genetics. And we work together and collaborate together worldwide. In the meantime, we have 36 centers all over the world on each continent. And we work together and share our experience. We publish data, we make conferences, we make temporal bone labs, we do lectures, and also part of this, we do every 3 months, so a quarterly hearing meeting like this, which is taped, and you will see later on YouTube. We set the standards since 2008. We work together in all types of innovation, comprehensiveness, coactiveness, and we educate people. Now, some housekeeping things. So please close all your other programs on the computer to can see us very well. Mute your microphone, and please name yourself because we are interactive. You can ask us questions, and we will try to answer those questions as best as we can. Your comments are very welcome, and the meeting, as I told you, is recorded. Now I want to introduce our outstanding faculty. I start from right to left, Professor Gunesh Rajan from the University of Western Australia, but also from Lucerne in Switzerland, a very well-known expert. Then Professor Paul van de Heining from the University of Antwerp. He's an absolutely outstanding specialist for decades. It's unbelievable what work he has done. You will find all this in the Medline. Now a new colleague, Privatdozent Nora Bice from the University of Bochum. It's her first hearing roundtable as a lecturer today at this time. Also a very well-known lecturer, Professor Margaret Dillon from the University of Chapel Hill in North Carolina. She has extensive knowledge of cochlear implants and rehabilitation and audiology. She did a lot of work and basic research. Last but not least, I wouldn't call it old friend, Professor Javier Gavilan from the University La Paz in Madrid in Spain, also one of the leaders in the field. He started, for example, cochlear implantation in acoustic neuroma patients. So we have a very outstanding faculty, and I hope you will enjoy this roundtable. Additionally, we have fully certificates. So we have the CPD standards through the University of Würzburg. So this is an official meeting you can add to your itinerary for your points to earn. And now let's start this roundtable about the electric neural interface. Please enjoy.
Hello, everyone, and thank you for attending the second edition of our Hearing Roundtable program this year. As Baumi mentioned, this is the 2023 Summer Hearing Roundtable. The Hearing Roundtable program was created during the pandemic, when online communications were the only way to share knowledge among us. And since then, we have been meeting 4 times a year with a large number of participants from all over the world. I must recognize that I'm not very keen on online activities, but the fact is that this roundtable series has demonstrated that we can reach a large number of people, many places, and a lot of professionals willing to spend 90 minutes 4 times a year with us, sharing, teaching, discussing, learning about hearing restoration topics. I hope you all enjoy today's roundtable. We will focus today on the ability to create an effective neural interface by improving the way we use the electrodes. And I cannot think of a more controversial topic in the world of cochlear implantation than electrodes. People may kill because of electrodes, but not reaching that end, the idea of discussing the shape, the length, the depth of insertion, the number of contacts, or any other issue related to electrodes may start a lively discussion in a matter of seconds. Over the next 90 minutes, our panelists will share with us their experience on electrode-related issues. They will tell us how to obtain the best possible results by properly using the technology that is currently available. Structure preservation will be the starting point of our discussion. We all know about hearing preservation, but structure preservation is step forward. We all want to be as careful with the cochlea as possible, preparing the field for the future developments that will undoubtedly appear very soon. We also want to match the anatomy of the cochlea to the electric stimulation provided by the electrode. In other words, aiming for the ideal neural interface for every patient. How deep we need to go into the cochlea? Is it better to use a straight electrode or a perimodular one? How do we assess the depth of insertion? And so many other controversial issues will be exposed and discussed today. But for this roundtable to be really useful and interesting for all of you, we need not only the opinion of our panelists today, but also your input. At Hearing, we want this roundtable program to be as interactive as possible. To achieve this goal, during the discussion, after each presentation, as Baumi was mentioning, you can ask the speakers directly by voice or give your opinion on the topic being discussed. You can raise your hand also on the connection on your Zoom program, or you can use the chat to connect with us. And we will try to address to the panelists all your questions and comments. And to start with this interaction and demonstrate that we really want you to participate, I would like to ask you to switch on the camera of your phones or your cell phones at home and scan the QR code you will have on the screen right now. You can also, instead of scanning this QR code, you can go to www.menti.com and introduce the 8 numbers you have there, 33566663, either using the camera to scan your QR code or introduce in www.menti.com the number 33566663. And with this connection, you will be able to answer some questions during this roundtable. The first question is just to know that you are there and you are using the connection we just provided. And it's a very easy one. Is which country are you connecting from? Where are you right now? And this is just to know where are you, and also to let you know how this application, this system works for the next questions that will be more related with the topic of discussion for today. So we have people from Switzerland, from Austria, Germany, Italy, Italia, South Africa, Australia, United Kingdom, but we have still not many people. We already have time for a lot of more answers. We see a majority of Central European people, also from the United Kingdom, also from Africa. Baumi was mentioning that the hearing group is present in all continents. And we have right now a new member from South Africa, and we have people now connecting directly from South Africa. Okay, we can move to the next question, which is, as I said before, related to the topic of this day, of this roundtable. The question is easy to read, easy to hear, but it's not easy to answer. Can a deaf cochlea still be alive? Can a deaf cochlea still be alive? And we have a yes right now, but I would like to receive more answers from the audience. We have more than 60 people now connected, and we would love to see your answer, your opinion. Do you think that when a cochlea is not hearing, is deaf, it is still alive, or being deaf means the cochlea is dead? So I cannot see the number of answers right now, but 100% of the people connecting is answering that the deaf cochlea, the cochlea who's not able to provide hearing to the patient, still may be alive. We can have some more time for answers, but I think the answers are extremely uniform. We have an answer also, people answering also in the chat, and the answers are all yes. We will discuss this during this roundtable. And now let me take you to a journey. We are going to make a trip all over the world with no jet lag. This is the good part of this roundtable. And the first point to stop will be Switzerland. We are going to Lucerne. And we are here to introduce you to Professor Gunesh Rajan. Gunesh is a good friend and a specialist in otorhinolaryngology as well as neck and face surgery. He worked as the professor of otolaryngology, head and neck surgery at the Medical School of the University of Western Australia in Perth, but now he turned upside down. You can see him down upside. And is the co-chief physician at the ENT Clinic Lux of Lucerne in Switzerland. Hearing is delighted to have him as one of our prominent members, and he will start dealing with the topic of preserving the intracochlear structures, structure preservation. Gunesh?
Thank you very much, Javier. Thanks, Baumi, for the introduction, dear hearing group, dear participants. It's a great honor to be again part of a roundtable. And as you already heard, we have quite an exciting topic today, and I'll try and breeze through the sort of super concentrated infos regarding how to do a surgery in order to preserve the structures in the cochlea, because that's essential for everything what comes afterwards, what happens afterwards with the cochlear implant. I would like to acknowledge a great group of people from the research group in Perth. Over the last 15 years, we're able to do this phenomenal work I'll be talking and reporting about. So I think it's quite interesting that, you know, cochlear implantation initially was purely for restoring hearing in deaf people. And over the last decades, it has evolved to not only preserving or restoring hearing, but actually also expanding the indication to patients who have some amount of residual hearing. So and there the foray of electric acoustic stimulation came up, combining the hearing in the implanted ear and combining it with the electric hearing of the implant, which gave a lot of benefits to the patients. And then from there on, we realized, that it's not only hearing preservation, the inner ear is much more. It's also the vestibular system. So we realized, well, we had to preserve the inner ear in total. And thus the term structure preservation arose. Because not only the hair cells, but also, the bony structures, especially the neural structures. So that evolved, and it was quite a fascinating journey. So how do we prevent damage to the intracochlear structures during cochlear implantation? You can see this beautiful image from our good friends, Professor Agrawal from London, Ontario, where you see how the electrode goes into the cochlea, into the scala tympani, and if we wanted to be there and cause least damage. And I think the key elements, and I'll just touch a few of them because they'll be quite a few will be part of the topic, is the patient factors, especially the anatomy and the genetics and the residual hearing. I'll touch briefly on the inner ear protection through pharmacologic agents. We'll talk about insertion mechanics, there a little bit about electrode array design. I will not talk about the intraoperative hearing monitoring because that's a big topic on its own. So I think it's really important for us, for me to conceptualize what's happening with the inner ear during cochlear implantation. I think a good concept is this two-hit concept of inner ear injury during cochlear implantation. So the first hit, the first trauma occurs during surgery, right? And then once that surgery is done, the electrode array is in, everything's good, the second hit follows. The second hit consists of all these various processes, mainly of inflammatory nature, which can have an impact on the inner ear health. And that can be days, months or weeks after cochlear implantation. So, and I think if we understand these two hits, we can sort of tailor our activities, the surgery and what happens afterwards in order to minimize these hits. So I'll briefly go through, the current concepts of how to tackle the first hit. So the first hit occurs during the cochlear implantation, when we as cochlear implant surgeons insert the electrode array. And a lot of this is about insertion mechanics. What happens inside the cochlea? So I think a lot of it is related to the changes of intracochlear pressures. So the first thing is, how do we open the round window? Already there, we know pressures can occur in the cochlea. So we know how to attenuate that. We do it underwater. The role of insertion speed, I think now that's universally accepted that the slower you insert, the better it is to preserve the intracochlear structures. The other little detail that's important is, I just want to mention that it's quite important to rest the hand with which you're inserting the electrode. Because as you can see on this slide, the black line shows a surgeon that rests his insertion hand, and the other two are surgeons that basically have freehand insertions. And you can see the variations in the intracochlear pressures is much higher if you do not rest the insertion hand. The array design is important. In your top left, you can see the intracochlear pressure rise in the perimodal arrays. On your right-hand lower corner, you can see the effects of the smallest lateral wall electrode on the intracochlear pressure change. So you can see there's quite a big difference, which is translated into the cochlea, a level is huge. After inserting the electrode, I have to point out the work's not done regarding preventing injury, because we know if you move the lead during the post-insertion, when you put the lead into the mastoid bowl, you can cause, as you can see on your left-hand side, you can cause a lot of pressure change. But that can be easily attenuated again if you fix the lead or hold the electrode and then place the coil into the mastoid ball. And then how do we tackle the second hit? Remember, it's the processes that cause the inflammation after the implantation. And there, of course, pharmacology is quite useful. And the easiest pharmacologic agent we have are steroids, glucocorticoids. So they are at the moment probably the most available unit, a drug which can protect or help minimize these inflammatory processes. And this is just a slide to demonstrate what happens is if you add on the top row, you add dexamethasone, and the lower lines of images is the control. And what you can see is, if you look at the right-hand side with the implanted ear, you can see in the guinea pig model, you can see that how well not only the hair cell structures are preserved, but also the neural structures, the spiral ganglions. So yeah, this is sort of in a super concentration, the effects or the techniques on how to try and minimize intracochlear injury.
Well, thank you very much, Gunesh. It's been a very clear presentation, and it's a concise presentation, and so we have time for discussion. Now, my first question will be, you mentioned that perimodiolar injury is bigger than the one from a straight electrode. A long straight electrode is more dangerous, makes more harm to the cochlea than a short straight electrode or than a perimodiolar electrode?
Well, there's sort of various dimensions. It's a good question. I think, especially if you look at the speed, it really doesn't matter how long the electrode is when you look at the intracochlear pressure changes. But I think the main issue is with the perimodiolar electrodes, the risk of tip fold over, which causes significant disruption, also pressure-wise, force-wise. And that's why, and that's also reflected. I showed one slide where, comparing the different array types with regard to the rise of the intracochlear pressure as the electrode goes in, and clearly there, the perimodiolar arrays have a much steeper increase in that pressure.
Good. Do you all agree? I mean, Meg, do you agree that a long straight electrode is not dangerous?
So we've seen some compelling evidence of hearing preservation with the longer electrode arrays, the 31.5 millimeter electrode array. So I think the impression that if you put in a long array, you're going to sacrifice the acoustic hearing or damage the structures is something we're learning a lot more about, that we no longer think that is as high of a risk as it was before, and now think more about what are those acoustic thresholds and whether it's better to put in a long array in case they lose hearing so that you can provide stimulation in that apical region. And I know some of the other panelists will get to that later, as opposed to putting in a shorter electrode array. So a lot to be learned, but feeling more optimistic about it these days.
Okay, we have a question from the audience. My good friend, Professor Hagen, wants to ask you something. Go ahead, Rudolf.
Okay, during the last ESPCI meeting in Rotterdam, Thomas Lennertz from Hanover presented his results, remarkable results with the dexamethasone-eluting electrode. Maybe you heard about this. So with very low impedance levels for at least 9 months, and also with a higher hearing preservation rate. What's your opinion on this, Gunesh?
Thank you for the question, Rudolf. Great point. I mean, the drug-eluting electrode is a beautiful example how to tackle the second hit effectively. So all these processes that are occurring after the array insertion, in the days, weeks, and months coming, it looks like with the drug-eluting electrodes, you can attenuate these effects. And that's great, because while the impedances because the impedances are so like a surrogate marker for the intracochlear fibrosis, we assume nowadays, right? And the fact that with these electrodes, drug-eluting electrodes, the impedances are staying low is a surrogate, basically indirect sign that obviously all these fibrosis inside the cochlea is being reduced or minimized, which is great, which is what we want. Yeah.
Good. I like your Ganesh, I like your slide about the resting hand. But I mean, for surgeons to introduce the electrode, even if your hand is resting, it's a very difficult thing just to keep always the same pressure and the same speed. So why don't we develop a robot? I mean, we are working on robots for just reaching the round window, but I think we need the robot just to insert the electrode. This can be done by a machine easily or not? It's a utopia.
Well, I think the tools are already here nowadays. There's various devices, insertion devices. There's companies that are focusing on this. They are actually, their portfolio is an insertion device for electrodes, right? And I think now it's on us to really use these devices and see what the benefits are, because they're all mechanical devices, and obviously they can certainly, as you said, they are far superior when it comes to the insertion and the speed and the amplitudes and the tremor elimination. They are all way superior to the manual insertion. But I guess time will tell which of these various devices now available are really successful and feasible as well in theater.
Okay, Paul, what's your opinion about the long electrodes and hearing preservation, just structure preservation, not hearing preservation? Paul, you're muted.
Yeah, okay. Well, we did a literature review comparing the different lengths of the flex electrodes. I have to insist, it are lateral wall, very flexible electrodes. And when we did this literature review, there was hardly a difference between the different lengths of electrodes. So more important is the use of the corticosteroids, the very, very slow insertion, and the non-atraumatic way of doing cochlear implantation. But the length on itself, initially, were documents, or we thought that long electrodes were more detrimental to the inner ear, but this literature review turned out that is not the case. So in choosing electrode lengths, this is not a main issue anymore, just like Margaret said.
Okay, Nora, I didn't forget about you, but I will address the questions to you after your presentation. So now let's keep with our journey and let's travel very easily from Lucerne to Bochum. And we came to Bochum in Germany to meet Dr. Nora Bice. Dr. Nora Bice. Nora is the chief physician at the Bochum University Hospital. Her work is dedicated to the therapy of profound sensory neural hearing loss by cochlear implantation. She is one of the world experts on the preservation of inner ear structure and the use of electrically evoked compound action potential. It is our pleasure to have Dr. Bice as one of our distinguished speakers at this roundtable, and Nora is going to deal with matching the cochlear anatomy. Nora?
Well, thank you very much, and good afternoon, everybody. Thank you for this very kind introduction. In this talk, I would like to give a brief introduction into how to assess the anatomy of the human cochlea from clinical routine imaging and how to apply this into therapeutic decision-making, but also and mainly to raise a certain awareness for the hints of and pitfalls when applying these methods. So when we want to assess the cochlear anatomy for patient individualized approaches, there are two major questions that we need to address. And the first one is what we actually really do want to measure and how to assess this as precise as possible. And second, how to reliably derive a decision from this information, such as the electrode choice. And these approaches may be completely different depending on whether we are dealing with a normal anatomy or with a malformation. Let's say, for example, in the malformation, we would rather address the radiological imaging to define the actual type of malformation, or maybe for volume estimation for later electrode choice. But due to time reasons, I'm going to focus on the normal anatomy in this talk. So in the normal cochlea, assessing the cochlear anatomy, which is the cochlear duct length, is of interest when approaching anatomy-based fitting, or when we want to preserve the residual hearing for electroacoustic stimulation. And then we would like to match the electrode's length to the residual hearing. And this we do under the aim of avoiding any crossover stimulations between electric stimulation and acoustic hearing. So first we need to identify the most reliable method to actually estimate the cochlear duct length. As an example, I want to introduce a study that we conducted in temporal bones, in which we compared 3 estimation methods for the cochlear duct length from 2 different imaging modalities, which is cone beam CT and high-resolution computed tomography. And the first method that we use is the A-value method, in which the diameter of the cochlea is put into a mathematical formula, and then the cochlear duct length is calculated. The second one is the so-called spline curve method, in which the CT is segmented. A 3D model is reconstructed, and then manually these dots are placed along the lateral wall. And the third one is a preclinical planning software that you probably know under the name of Autoplan, in which the investigator measures the 2 diameters and the height of the cochlea. And we compared all these methods to a control group, and we found that there was an underestimation of the cochlear duct length from all methods. However, what we also found was that there was a very good interrater variability for the clinical planning software. And when we know that the software applies a correction factor and we do away with this correction factor, we found that we could diminish these differences, so that we identified this method as a suitable approach for further application. However, when applying these methods in clinical decision-making or fitting, we need to be aware that of these estimation inaccuracies. So we investigated these in another study where we preoperatively measured the cochlear duct length, and we chose the electrode to cover 75% of the cochlear duct length. And then we measured the actual angular insertion depth from postoperative CT imaging. And what we found is that there was a significant difference between the preoperative estimation and the postoperative measurements. And this is just to make you aware that we have to highly systematically standardize these methods for future applications. But when we applied a correction factor of 5%, we were able to diminish these differences again. And this one is just as a short outlook on how to present another promising opportunity to address these electrode positioning even more precise. And this might be a combination of the both radiological imaging and electrophysiology. So this is from a study where we wanted to match the characteristics from compound action potentials to the cochlear duct length. And what we do already know here at the example of the ECAP slope is that the more apical we get inside the cochlea, the steeper the slope gets. So what we did in these studies is we only looked at the most apical electrode contact, under the assumption that the most apical contact is located closer to the apex in a small cochlea, but farther away in a bigger cochlea. And we could prove this, that there was almost a linearity for the ECAP slopes that were steeper in smaller cochlea compared to the larger ones. So this indicates that a combination of the both may be a promising approach for future investigations. So what can we conclude? Patient individualized implantation seems to be feasible, but it requires an interdisciplinarity, since we need the most precise information from the neuroradiologist, the surgeon, and the audiologist. But it's very interesting to approach this systematically in prospective evaluations. For example, to ask questions about the benefit from a deeper insertion or the reliability of such position monitoring methods. And with this, I would like to thank you for your attention.
Thank you very much, Nora. It was great. Again, very clear and concise. So let's go back to the discussion. I mean, we all agree that we need to do an individualized medicine right now. I mean, the one size fits all doesn't work. But to what extent the brain, the plasticity of the brain, can match the mismatch of the electrode?
That's a very interesting question, and I'm not sure whether we are already able to answer this in a full extent, because this also seems to be very technical, and we know from many studies that even when inserting a very short electrode, after some weeks, the hearing seems to be possible. Even, for example, we know this from patients that lost their residual hearing during EAS surgery. But I think one thing which is interesting and what we have to have a further look at is that there seems to be a faster benefit from the deeper insertions, at least in the approach of lateral flexible lateral wall electrodes.
Rudolf, you want to ask something? Oh, your hand is still raised. Okay, no problem.
Okay, no problem. There are big differences between the different ways how to measure cochlear duct length. What kind of CT are you using? I was told by my coworkers that flat panel secondary reconstruction gives the most precise results because there are differences between 3 or 4 millimeters in the cochlear duct length. What's your opinion on this?
Yeah, there are very good works from the study group of Kristen Rack on this, and I totally agree that the flat panel CT is a very good approach. But at least in our study, we did not find differences, or at least not very large differences between cone beam CT and the high-resolution computed tomography. I think what is important in the first place is the slice thickness, that should not extend a certain thickness. But then we also need to know that even CT, there are so many differences between the quality of the imaging, and the same applies to the cone beam CT. So this is something that we really need to address, that the quality very much depends on the type of CT or cone beam CT that you are using, and that is available in the clinics. So there's a large variety and heterogeneity in between the studies that are available.
Thank you very much. I want to ask you a question to all the panelists. How do you individualize? How do you choose the type of electrode for your patients in the everyday's life? Can you tell the audience? Paul?
Yes, we use the Autoplan to measure the cochlea, or to analyze the stacked CTs and to measure the length and the width of the cochlea. We did also a study comparing the prediction of insertion depth with the actual insertion with CTs postoperatively. And indeed, we systematically underestimated the insertion depth of the electrode. But we found the most reliable data and the least variability between autologies, between different autologies, looking at the same CTs and analyzing when using as well the length as the width of the cochlea, using the electrical cylindrical application instead of only using the length with the Alexiadis type of calculation.
Unesh, what did you use before? Would you use the same as you were using in Australia? How did you do it?
Yeah, it's funny. Yeah, same with Paul, we used the auto plan. So we started using that in Australia and really have maintained that practice over the last few years now, because as Paul said, you know, we under or overestimate, and usually there's much more room for a longer electrode than we think. So, and I think that another, you know, we looked at the correlations between incomplete insertions and the measurements, you know, preoperative, and obviously, you know, that it's a very reliable way of making sure that you can put the longest electrode in and completely insert it.
You do the same in Chapel Hill, Meg?
So we currently are not using imaging for electrode array selection preoperatively. That technology has only recently been FDA approved in the United States. And so we're starting to implement that into our practice. And so really it's the unaided audiogram that's driving decision-making regarding whether to put in a short array or a longer electrode array.
Okay, now, if we all consider that we underestimate the length of the cochlear, the length of the cochlea, this means that the manufacturers need to produce longer electrodes, more than 33. That I think this is the longest we have right now. What's your opinion? Nora, you can start.
Well, first of all, when we measure with Autoplan concerning the lateral wall electrodes, what we do ourselves is that we apply this correction factor so that we match the 75% that we want to reach. But yes, in those cases, when we say that we want to cover 75% in this approach, then we have to be consequent, and then we would need longer electrodes to cover the largest cochlea that we have.
Paul.
Yes, indeed. For the larger cochleas, we probably need longer electrodes, not the 31 millimeter, but the 34 millimeter. And the first data appeared already of this electrode. So for this type of electrodes, we need them. But after the work of Nora, we will surely apply this 95% or 5% adaptation to our way of working.
Okay, and do you think, I mean, what's going on above 540 degrees or 700 degrees? Is there still a chance to stimulate even higher, more than, let's say, more than 700 degrees? Nora?
Well, from all that we know, there does not seem to be that effect any longer. The studies that I was mentioning last was where we included patients only with 31.5 millimeter electrodes, and there were many of them that had a cochlear coverage between 80 and 90% with this, and we found that above a certain point, which was around 80%, we did not find any correlation to the post-operative speech perception. So maybe too deep is not what we need to assume or what we need to achieve.
There's a black hole after 80% of the cochlea, right? Okay, well, let's move to the next step of this roundtable. Thank you very much. We'll keep with the discussions after the next presentations. But before, can you please go back to your cell phones, to your mobile phones, and we will go back to the Mentimeter to ask about one more important question. Remember, going back to Menti, www.menti.com, and entering 33566663, or just scanning the QR code. Can you tell us, in your opinion, how important is to stimulate the apical part of the cochlea? I mean, for all of us in doing cochlear implants. We know that some people consider that you don't need to go up there. How important is for you to do what we were discussing before, going to 80, 70, 80% of the cochlear duct length? You can say it's very important, you can say it's not important at all, you can say it depends, or you can say, well, it's important, but no more than that. And the results up till now, we have nearly 50% of our answers saying it's very important, 25% it's important, and the maybe and not important is like 18 and 9%. So it's a discussion, but the majority, well, not the majority, half of the answers go in favor of the it's important to stimulate the apical part of the cochlea. And I would like to, while I wait for the last answers, I would like to ask the panelists in the next after the next presentation why they consider it is important or not important. But you see, it's more or less 50% for very important, 1/5 of important, 1/5 of maybe, and around 8% is not important. Okay, so now let's continue our journey, and we are keeping in Europe. We moved from Switzerland to Germany, and from Germany to Belgium. We are going to Antwerp. And we came to Antwerp to meet Professor Paul van de Heine. Paul is a good friend, an excellent person, a great professional, and he's the professor of the Department of Otorhinolaryngology, Head and Neck Surgery at the Antwerp University Hospital. His research is focused mainly on inner ear pathology and cochlear implantation. And together with his team, he has pioneered the application of cochlear implants in single-sided deafness and tinnitus. The hearing group is lucky to have Professor van de Heine as our vice chairman. Paul is going to deal with the importance of covering the neural apex. And please, Paul, can you tell those saying that it's not important why it is important in your opinion?
Thank you, Javier, for this nice introduction. And yes, I'm in favor of stimulating the second turn of the cochlea or the neural apex. Indeed, when using these long electrodes, 31 and 28 millimeter lateral wall electrodes, the apical tree electrodes from these long arrays are located in the second turn of the cochlea. And we studied, and we'll discuss now, what this means for the patient. Do the patients hear something more or something differently by stimulating these apical electrodes in comparison with the electrodes in the second turn? First of all, I'd like to emphasize that the apex of the spinal ganglion extends in the second turn up to 690 to 720 degrees, and it ends up with a kind of a bulb conglomeration of spiral neurons. And also histological studies showed that about 25% of the spinal ganglion neurons are located within the second turn and are located in the apex of the cochlea. So it must help the patient in some way to use these 25% of spiral ganglions by being able to stimulate them through electrodes that are located in the second turn. To know that, we used patients with a single-side deafness. There are patients that have a normal hearing from one side and that have a cochlear implant from the other side. And these patients can tell us how the electrical stimulation compares with the acoustic stimulation at the normal side. So we started by stimulating each electrode and asked the patient to pitch match this, so to define what is the pitch of the tune that they hear in the normal ear. And these were the first results. when we stimulate the apical electrodes, and here you see at the x-axis the insertion depth. This is at the round window, and this at 2 turns. When we look, for instance, at 1 turn, the average perceived pitch was around 700 hertz. However, when we look at the more deeper inserted electrodes at the apex, then we see that patients can hear much lower frequencies. And then the second part of the experiment was done by the group of Rader, and so they used the Greenwood function, and they defined by the Greenwood function what would be the corresponding frequency. For instance, if you use 450 degrees, it is 300 hertz. If you have an electrode at 540 degrees, it would be 200 hertz. Well, they applied these frequencies, so 200 hertz, for instance, for 540 degrees, at those electrodes, so corresponding the Greenwood function. So in the first experiment, all electrodes were stimulated at a rate of 1500 hertz, like in a CIS strategy. And in the second experiment here, the electrodes were stimulated at rates that corresponded to the Greenwood function. And you see there's a lot of less variation in it. And also patients had also lower frequency perception. And then we come to the third part of these experiments. And we presented to the patients low frequencies at the acoustic ear, 100 hertz, 200 hertz, 300 hertz, 400 hertz. And then we asked the patients whether they could get the same pitch by varying the frequency of electrical stimulation at the cochlear implant site. Okay, this is nice to ask to the patient, but were they able to do that? And this is expressed here in the y-axis. 100 means that all the patients for all the electrodes were able to match that particular pitch that was presented at the acoustic ear. Well, if we look at the apical electrodes, these are the red ones, we see that the majority of patients, 80% of the patients, were able to match low tones, were able to match 100 and 200 hertz. Whereas the electrodes in the basal turn, the blue ones, were unable to do that. When we look at higher frequencies, like 400 hertz, then the apical electrodes are unable to generate that same pitch, whereas progressively the basal turns were able to do so. So what can we conclude with this? We can conclude, first of all, that electrodes in the apex are sensitive to change in frequency of electrical stimulation, and that in order to realize that the patient is able to hear low tones below 300 hertz, you need electrodes in the apex, and you have to use frequency following stimulation rates. So low rates, if the tone is 100 hertz, then the stimulation rate has to be 100 hertz. When it is 200, you have to use 200 hertz stimulation rate. And we come to the final conclusion. As said, it is absolutely necessary for patients to hear clear low tones under 300 hertz in this way, and they are essential for the perception of rhythm and prosody, and also it improves music appreciation and speech in noise recognition. Thank you for your attention.
Thank you, Paul. That was also very clear. And I like very much the way you address the issue of long electrodes. So now I would like to ask you, the panelists, and you also, well, you already mentioned, Paul, do you have experience with patients with long and short electrodes? And can you tell the audience what's the difference? Because this is facts. Meg.
As far as speech recognition, is that what we're talking about? So for long electrodes, we are seeing that there is better performance on these sentences and quiet, particularly sentences and noise task as compared to short electrodes. And this is speaking with cochlear implant alone users, so those that don't have residual hearing. So a few years ago, we conducted a randomized study of subjects that received a 24 millimeter versus the 31.5 millimeter and saw pretty convincingly within those first 12 months that the longer electrode array recipients did better in noise than the shorter array recipients. And then recently looked at the performance of that patient sample at 4 years and saw that that difference remained. So at least for electric stimulation alone, we do see this difference as a function of electrode array length, which we think is also a function of where we're presenting that frequency of information relative to cochlear tone and typicity.
Great. Nora?
Well, I must say from these patients, the best thing to answer is that from people that lost their residual hearing in EAS surgery, because usually we would like to address this 75% of the cochlea. So we try to standardize on the insertion depth when using lateral wall electrodes. But those that lost their residual hearing using a shorter electrode array, that it took them way longer to get to the same speech perception levels than the ones with the longer electrodes. And I think this is in line with several other studies that found that when using lateral wall electrodes, we have the effect of faster hearing learning. And we recently conducted a review on the effect of deeper insertion on speech perception. And this is something that many studies report on, that they have an effect, a correlation between the insertion depth and the speech perception outcome. But in several studies, this effect diminished after 12 months.
Good.
So,
I will go to the audience in a minute, but just let me finish this question with Gunesh.
Yeah, I think it's a very fascinating question. I think the recent insights, from Sumit and Agrawal and Helge Rask-Andersen into the anatomy, into the apex are quite crucial, and actually explaining the experiments, Paul demonstrated. Showing that in the apex, you have the stimulation rate-based sensitivity of the cochlea as opposed to the basal turn, which is more frequency-based and it has sensitivity. And I think we've learned also from the single-sided deafness patients, we have learned that those with shallow insertions, with shorter electrodes, clearly have, this pitch confusion. So their input frequencies remain always higher remain in the high frequencies. So which is a clear sign, that a lot of people say, there's plasticity of the cochlea, right? But I think the single-sided deafness patients with the shallow insertion are good examples that there's a limitation to the plasticity in the cochlea. And if you don't get there with the electrode deep enough, that you'll always cause pitch and spectral confusion in these patients.
Good. Paul, you wanted to say something?
Yeah, of course, the patients that have residual hearing at the low tones, they benefit from the percept of these low tones. And this is also the reason why they perform so well and have also a very pleasant sound perception in AS patients. When they lose the low tones, well then, apical electrodes can substitute for the loss of this low tone acoustic hearing, but on the condition that you have low tone frequency range. And also when we look at these publications that relate speech in noise with insertion depth, then we see that there is a progression only in those cases or in those patients that use fine structure stimulation in the apex. When you use CIS, there's not so much advantage of inserting electrodes deeper than the basal turn.
Good. Good. Thank you very much, Paul. Rudolf, go ahead.
Yeah, Paul, this bulb looks a little strange, isn't it? So you have this bulb near the apex, and if you have an electrode near this bulb, maybe your stimulation is not as precise as in the other parts of the cochlea. What's your opinion? Because there's a conglomeration of neurites in this bulb, and how can you solve this problem?
Yes, this is 100% right what you're saying. You have a conglomeration of all these dendrites and neurons, but we see that localization is not so important. So when we stimulate the apical electrodes with the same frequency, then the pitch is nearly the same. They do not differentiate based on the location or the insertion depth within the second term, but they make a difference by the stimulation rate. So apparently these ganglions are sensitive to frequencies or to the applied frequencies and not so much to the place. So it is more temporal characteristics that allow us to make different pitch sensations and not the location on itself.
Good. I would like to ask you a difficult question to each one of you. And I just want 2 words as an answer. Tomorrow you need a cochlear implant, all of you. You want short or long, and you want straight or curved electrode. Paul.
Long and straight.
Meg.
31.5 lateral wall.
Go. That means, I mean long. I mean long above 28. Okay, so long.
I can't give a 2-word answer. Yeah.
Yeah.
Great, Nora.
Long and straight.
Gunesh.
Straight and long.
So I'm amazed why so many not straight and long electrodes are used in the world. Anyway, we'll keep with our discussion. For all of you, I mean, for not for Paul that I already mentioned and Gunesh, for Nora and Meg, how important is the use of cochlear implants in single-sided deafness to understand what's going on with frequency match? Nora.
So
Oh, no. Go ahead, Meg. Go ahead.
So we've conducted similar studies as Dr. Van de Heining and his team of looking at pitch matching between the ears, and saw that patients were able to do that very early in the process. And unfortunately, we did our first measures at 1 month, and I was kicking myself that we didn't do it earlier because they had already matched. And what we're seeing clinically is that these patients that have the longer arrays tend to do better faster, but they also report a better sound quality with the longer array than they do the shorter array, which has really led our team into the importance of aligning that frequency information with cochlear place, but also with the information that they're getting from that contralateral ear. So I think it's a provocative area to study, but also I think we're going to see that importance of matching between the ears.
And Nora?
Well, there's rarely something to add to this, because maybe rather from the qualitatively point, the use of the single-sided deafness users is that we have the opportunity to assess the actual quality of hearing, because there are many studies that talk about the speech perception outcomes, but this does say nothing about the actual pitch perception and the perception of music and that stuff. So this is the meaning that single-sided deafness patients may add to our studies and the information that we can gather from them.
Good. Okay, let's move to our last trip today. And now this is going to be a long trip, because we're moving from Europe to the United States, to Chapel Hill. And we came to North Carolina, to Chapel Hill, to meet Professor Meg Dillon. Meg is the director of cochlear implant clinical research at the University of North Carolina at Chapel Hill. Her research is focused on new indications for cochlear implantation, as well as individualized mapping procedures for cochlear implants and electric acoustic stimulation devices. She belongs to a team of researchers, audiologists, surgeons, and speech pathologists at UNC, dedicated to improve the treatment of pediatric and adult patients with hearing loss. And the hearing group, our group, is delighted to have Meg as one of our more active members. And Meg is going to deal with the last topic of this roundtable, which is the use of imaging to personalize the map. Meg.
Yes, so thank you so much for the invitation to participate in this panel. This is one of my favorite topics, and so love to always have the opportunity to share some of these data and talk a little bit more about this with other groups. Would like to also acknowledge and thank the team that we have, because as you all know, that we cannot do this work without a dedicated team of surgeons, audiologists, and speech language pathologists. So at our center, the traditional use of imaging is really interoperatively. So it's standard of care for pediatric and adult cochlear implant recipients to receive an X-ray. And then for our adults, they receive a postoperative CT, with the goal being, have we placed the device appropriately? And are there any extra cochlear contacts that we need to think about deactivating? Is there evidence of tip fold over, and any surgical decision-making that needs to be made at the time of implantation? But more recently, we've had tools become available where we can use imaging to better understand how to program these devices. And so it's already been mentioned that Otoplan is available, and this is a tool that we can use both preoperatively, but we have been using it postoperatively to determine where the cochlear implant is and hopefully help us identify better ways to program. So when we first got Otoplan, we looked at a number of subjects that received either the 24, the 28, and the 31.5 millimeter electrode array, and saw that the variability in angular insertion depth is pretty wide for recipients of the same electrode array. And these are all full insertions. And what that tells us is that cochlear morphology is contributing a lot to where these electrode arrays end up. We can't just assume that someone who has received a 28 millimeter electrode array is going to be at a place of about 250 hertz, that it could be anywhere from 750 down to 125 hertz. And unfortunately, the way that we program these devices currently does not take this into consideration. So for cochlear implant alone users, we provide these default filters of 70 to 8,500 hertz. And by not accounting for place, we have a discrepancy between the frequency information we're presenting and the cochlear place frequency, which is known as a frequency to place mismatch. And so what that looks like is here, if we have the default filters of 70 to 8,500 hertz for this recipient, I'm presenting 120 hertz to a place of about 550 hertz. So we have a discrepancy between what we're presenting and that cochlear place frequency. For EAS, it's a little bit more complicated, which is also why it's one of my favorite topics, because now we're thinking about the individual's unaided thresholds. In this case, the patient is implanted in the left ear. So first we identify that region of functional acoustic hearing. We're going to represent that acoustically. And then we use the high frequency of that functional acoustic hearing as the low frequency filter of electric stimulation, and then just provide the rest of that frequency information across those active contacts. But again, we're not considering where that electrode array is. And so we are having frequency to place mismatches in this population as well. And just to show that with a picture, first we identify that functional acoustic hearing, which is represented here in blue, but then I place 313 hertz to a place of about 550 hertz. So again, an electric mismatch in this patient. As we mentioned earlier in this panel, we have patients that have long electrode arrays that have hearing preservation, and we have seen a high incidence of about 60% of our patients that are using EAS have one or more contacts within that functional acoustic hearing region. And again, we're not considering that when we map, but now we have contacts that could be masking that low frequency hearing, and we have electric frequency to place mismatch just shifted the other way. Now, we know that this can have negative effects on monaural hearing. It's been shown for vowel recognition, word recognition, sentence recognition, and noise. As mentioned earlier, there is some evidence of acclimatization to electric mismatches, at least in CI alone users. However, it is not always complete, and it's not something that all patients experience. So we think it's important to be considering. And as we start talking about single-side deafness, bilateral users, the negative effects of electric mismatches on binaural hearing are also evident, which are also referred to as interoral mismatches. And this has been shown pretty consistently in bilateral CI users, where these shifts in frequency information result in poorer binaural hearing abilities. So what we've been doing is using that postoperative CT to calculate the angular insertion depth, and then we adjust the electric frequency filters to match the cochlear place frequency, which is what we refer to as place-based mapping. And the big question is, does it work? So these are data from EAS users at 6 months post-activation on monaural hearing tasks. So on the left, you have vowel recognition. On the right, CNC word recognition, which is a monosyllable task. You have electric frequency to place mismatch on your x-axis. If they're in blue, they're in a place-based map. If they are in open symbols, then they're in a default map. And what we see is even at 6 months post-activation, when we'd expect patients to reach a plateau in speech recognition performance, there is this significant association with those that have greater magnitudes of electric mismatch have poor speech recognition. The same is true for binaural hearing. And so again, this is 6 months post-activation, EAS users this time with normal hearing in the contralateral ear. And what we are seeing on this BKB SIN, so lower value indicates better performance, and this is in a challenging 4-talker masker, is that those that have a place-based map or minimal magnitudes of electric mismatch tend to have better performance in noise than those that do not. And I want to draw your attention quickly to the squelch conditions where we're putting that masker towards the implanted ear, that we see that those that have minimal amounts of mismatch or in a place-based map are showing better binaural hearing abilities than those that have greater magnitudes of mismatch. And that relationship is significant, whether or not we include this patient out here that has the largest magnitude of mismatch. And thank you for your attention. I promised I'd try to keep it to 5 minutes.
Thank you very much. Thank you very much, Meg. You did it wonderful. It was very clear. And this leaves us for the last 10 minutes of discussion before closing this roundtable. And I would like to start by asking the audience why they are so quiet, because no one is sending anything from the chat or raising the hands. Remember, you have the chance to ask all these experts all your doubts, and we still have 10 minutes for that. So right now, I would like to focus on one thing. We were dealing before with the importance of single-sided deafness, cochlear implantation in single-sided deafness. And Meg has raised the question of how important is cochlear implantation in electroacoustic stimulation to understand how cochlear implants work. I mean, Nora, Gunesh, Paul, you start. Nora, do you think this is also important, like it was for single-sided deafness, or more, less important, the same? What do you think?
Well, you mean concerning the EAS users?
Yep.
I think what we, the major task that we learned from them is how important preserving the residual hearing is. For example, in these studies where the electrode lengths were compared among patients that had a CI stimulation alone, whereas the acoustic stimulation, we found that there were large differences. So I think this is the major lesson that we learned from EAS users, that we should do everything to preserve the residual hearing, even in those patients where we would probably only stimulate electrically.
Gunesh?
Yeah, I mean, that's a good learning point. I think another learning point is, and that's why we are getting better at, is with the, the correlations with anatomically through the autoplan software, all these possibilities on measuring precisely and then measuring where the electrode is. But one difficulty remains is that all these patients with residual hearing is, if you have 100 patients who have the same low frequency levels of hearing, right? The variation of what they get out of this residual hearing, there's a huge variation. And I think we, at the moment, it would be good. We're getting better at it, identifying which patients benefit from their residual hearing, and and others not. And in those, you would use a longer electrode, for example, right? So I think that's still we're still grappling a bit in that space, but we're getting closer and closer. Yeah.
Okay, thank you. I will go back to you, Rudolf, in a minute. Just let me ask the panelists a question coming from the audience. Finally, we got one in the chat, and it says, what is the long-term results with EAS and shorter electrodes? Meg.
As far as hearing preservation, I mean, I think it's been discussed earlier that we've seen hearing preservation rates that are similar, that Dr. Van de Heining said that he had conducted a study reviewing that. So that's something that is worth paying attention to. For speech recognition, I think having this mismatch is important to consider. So I think we all agree that you should save as much acoustic hearing as possible. It has been shown repeatedly that adding that acoustic hearing to electric stimulation is beneficial. But as just mentioned, there is continued variability in patient outcome. And I think the piece that we've been missing is this electric mismatch. And we think that it might be an issue for these shorter array patients, because now you have acoustic hearing that could be serving as an anchor to cochlear place, making it harder to shift to these electric making it harder to acclimate to these shifts in electric stimulation. So that could be driving some of that performance variability. Now, the data I showed you was 6 months. Maybe eventually these default users catch up over time, but some of the preliminary data that we are seeing is that's not always the case.
Rudolf, you're the most active member of the audience.
Like always. My question, Meg, great talk. Had you ever seen patients who had problems with this electrical mismatch over a longer period of time, or is the problem solved by the plasticity of the brain? And looking, maybe these mismatches are only in patients who had ever normal speech, because in children, for example, when you turn on, and this is the first hearing experience, what's your opinion on this?
Yeah, so I think your first point is an important one to consider, is that we do see that patients have this steep growth in speech recognition over time, and then they hit that plateau. And so it could be that some of them acclimate to these mismatches and they do fine. But I think some of our data now is showing they may do fine on monaural hearing tasks, but when you combine that in a binaural hearing listening condition, that they may not be adjusting to these mismatches. And something that we have been doing is taking experienced listeners of these default maps where they have these spectral shifts and switching them back to a place space. So to comment on your second point, these are post-lingually deaf. So folks that have had that normal tonotypicity and normal experience. And if we switch them back to a place-based map or normal tonotopic organization, we're seeing better performance than what they ever achieved with a default map. So now that's in a handful of patients. This is something early that we've been doing, but I think that is compelling for why we should move forward. Now in children, it's, I think an excellent topic of, is this something we should be doing right out the gate, or can you trust that their auditory systems will adjust to that? I think we need to think a lot about if they were implanted bilaterally before that critical age, as opposed to unilaterally and then getting, a second cochlear implant later. I think that would introduce some variability in those outcomes, but definitely more to learn on that topic.
Okay. Thank you very much, Meg. One more question, Meg. Stimulation rate. Can you tell the audience, because when we hear about stimulation rate, you consider, well, as much, as higher as possible, the best. But I don't think this is the real thing. Can you tell us what's the ideal stimulation rate for a cochlear implant?
So I agree. I think the jury's out on that, right? Like I think we saw with the advanced bionics devices, when the Fidelity 120 systems came out, that we thought patients must do better with these faster stimulation rates. And we saw some did, some didn't, and some did about the same. And I think it is another parameter that we're going to have to start to consider for the individual, because, a few years ago, we thought, well, older adults can't handle these fast stimulation rates. We should slow it down so they have better performance. Same situation. Some did better, some did worse, some did the same. So I think that is something where we're going to have to evaluate it on a patient level basis. Now that is considering CIS style strategies. If we're thinking strategies that are including some of these fine structure cues in the apex, and that's a whole different beast and an active area of investigation. And
another tricky questions. Number of electrodes. I remember when I started cochlear implants back in the 90s, we were using the in-rate. It was like I think it was 4 or 6 big balls stimulating the whole cochlea. Now, the results were, I mean, not the same as we're seeing now, but patients could hear. So what's the ideal number of electrodes? How many contacts do we need? Do we need many? Do we need less? What can you tell us?
Is that for me?
Yeah, that's for you.
So I would say what we see with the normal hearing simulations, normal hearers need 4. And then there were the early studies that showed that cochlear implant patients need 8. And then anything beyond that, they start to plateau. And now there's been more recent studies that have shown 12, 16. Again, we're seeing this variability in the benefit that could happen. And I wonder, is that because we're seeing patients with better hearing getting cochlear implants? And so they have better frequency resolution than what patients 10, 15 years ago had when we were implanting them. So I don't think it's well known. And again, I know I sound like a broken record now. I think it's going to be specific to the individual. I really want us to move more towards individualized device selection, individualized device mapping.
Okay, I will give you one question from the audience in the chat. The question says, is there effect of using full banded versus half banded electrodes on residual hearing? Nora?
This is a very audiological question.
Yeah, I know.
So probably Mag would be the right person to answer this.
So I don't think it really is an audiologic question. I think it's an electrode array design question, because the reason we went from these full banded to half banded was to make that apical tip more flexible. So on the current flex electrode arrays, the 5 most apical contacts are single banded, allowing, we think, for better hearing preservation than what was happening with the full banded. So I don't think that, at least in the hearing preservation work that we have done, I don't know if we necessarily have that data to say that that was better for hearing preservation or not, just because we weren't using those longer electrode arrays in hearing preservation cases at the time.
And the last question also coming from the audience, is it recommended to use longer electrodes with single-sided deafness or patients who use hearing aids in contralateral ear? You want this, Nora?
Yeah, well, I think this is an interesting topic, and I think from what, at least from my experience, in single-sided deafness users, the longer electrodes seem to have the effect of that we have at least the opportunity of better matching the implant to the normal hearing ear.
Okay, I think we are just about to finish. We have been almost 1.5 hours addressing the state of the art of the neural interface in cochlear implants. In other words, trying to clarify how can we improve the outcomes of cochlear implants using the electrodes in the best possible way. Many questions, of course, are still open, but the development of our knowledge up to date on this crucial issue has increased exponentially. And it has been doing this on a very short period of time. We know now that the final aim of cochlear implant is to reach out and excite as many neurons as possible in the most physiological way, not only the quantity, but also the quality. The images coming from the synchrotron improved our understanding of the cochlea in a way no one could imagine before. From these images, we can see how alive the cochlea still is. A deaf cochlea is not a dead cochlea. Even when it looks dead, it's still alive. And how it can be optimally addressed with an electrical signal. Of course, this is just the beginning of a new era. And when I started, as I mentioned before, in this field more than 30 years ago, we wanted deaf patients to be able to hear. Now we want them to have a physiological stimulation of the cochlea that may provide a natural hearing and music perception of quality, and hearing discrimination, speech discrimination in noise. So we want a lot of things that we didn't want at the beginning. And lots of research and development is still needed, but a new door is open towards a more natural hearing. Surgeons, we should be aware of the importance of structure preservation, not only hearing preservation, but be careful with the cochlea for two main reasons. Number one, for an improved outcome in the immediate result, and number two, for preparation for the future, a future which is just around the corner. Audiologists have to continue developing new strategies to improve speech understanding, and engineers and manufacturers should develop new technology for audio processors and electrodes to provide full benefit for the future cochlear implants. Who could imagine back in 1990, when CIs became easily available, the things we have today, 30 years later? The revolution of natural hearing with cochlear implants is just starting. Well, after these conclusions, we are almost out of time. I just want to thank you all, the panelists, for their great presentations, and the audience for being there. And before closing, let me just tell you some practical issues. At Hearing, we want you to visit us, to stay with us, to ask us, to tell us your comments, your opinions. And you have to do that by visiting www.hearing.com, where you can find tools like the hearing preservation calculator, the counseling platform, the EAS fitting tool. And you can also use our learning management system, our platform, the Hearing Boost, which is the place where we have the most important pillar of the hearing, which is teaching. And it is also in our webpage, if you go to boosthearing.com. For young people now connected at this time, it was mentioned at the beginning, but you can also find certifications for our courses. You can get a certification, a CPD credit for this roundtable 1.5 accreditation. You can request the accreditation by email at boost@hearing.com. And you know, the procedure will take some time to complete, but in about 6 weeks, you will receive 1.5 points for the hour-and-a-half duration of this roundtable. We're becoming a very active group. As you can see here, we've been going to meetings, to international conferences this year, and we're planning to go to Asia Pacific and JICA in the future. And we will continue with our roundtable program in that way that I would like to tell you that the next roundtable will be live streamed directly from Vienna for the National Congress on 28th of September this year. It will be live streamed directly from the Congress in Vienna. Please send us your doubts, questions, or comments to www.hearing.com, and we will be more than pleased to answer you, to contact you, and hope to see you back in our next roundtable from Austria. Meanwhile, keep safe and goodbye.